It's a pleasure to be here speaking to you today. I am admittedly a little disappointed. I thought I was going to be the first one to mention the mitochondria today. I was just beat by that by just a couple of minutes, so very excited to hear about the mitochondria, which are near and dear to my heart. So just a really brief bio, and I have no financial disclosures, as pretty much no one else has either. So I'm the owner of the East Coast Naturopathic Clinic in Bedford. I'm joined there. All right, I advance, right. Yeah, like, what's PowerPoint? I just don't even know what this stuff is. So I'm joined in Bedford by three fellow naturopathic doctors. I have one naturopathic resident, and we have four amazing support staff. To date, I've treated over 650 cases of suspected or known persistent borreliosis, sometimes commonly known as chronic Lyme disease, and co-infections to date. I've also consulted on many other cases, so local colleagues or other colleagues around North America who call or email me for my input on their cases. And then I also lecture about these topics at various medical conferences around North America, primarily in the States, but sometimes in Canada. And then just in the last year, I started teaching about Lyme and co-infections at my old naturopathic school, the Canadian College of Naturopathic Medicine in Toronto. So now it's a mandatory part of their curriculum to learn about Lyme and co-infections, which... there we go, thank you. So that's something that has just started, and I'm hoping that that trend will continue to other educational institutes around North America into the future. All right, so I was asked to talk about testing options and treatment options. It's really great that some of the treatment options have already been talked about. Dr. Lambert and others had touched on these. It is very true that unfortunately the non-standard testing options are not as evidence-based as we'd like them to be. At the end of the day, like any test, whether it's the standard serology or some of these non-standard tests that are out there, we just have to really rely mostly on clinical judgment, looking at the whole picture of the patient, but sometimes we do use some of these tests to help to push us in one direction or another with a case. And it is on my agenda. I'm actively working on trying to get some studies underway to help validate some of these non-standard tests more regular, or to a greater extent. In terms of talking about testing and treatment options, I thought that the most effective way to communicate that would be talking about 4 different case summaries. When I was reflecting on my practice in preparation for this lecture, I realized that the hundreds of cases I've seen to date, they could really be fit into 4 main categories. And so these are the categories that I lump them into. And unfortunately, my patients don't actually say these things to me. It would make my job so much easier if they just tell me what was wrong. But after I've taken their case or I've seen how they've been responding to treatment, their cases ultimately speak to me saying generally one of these 4 statements. So either a case where they need antibiotics but they can't access them, or I've been treated for Lyme but I'm still quite sick, or I've been treated for Lyme and maybe other things and I feel better but I still don't feel fully healed. And then the final category is, it really sounds like I have Lyme, but I actually don't. So we're going to talk about all of those in more detail. So the first case is the case of, I need antibiotics, but I can't get them. And so these will be the cases where after listening to the patient, it's like, you just need more killing support here, but either they can't access a longer course of antibiotics, or they can't get them in the first place locally, or they can't afford to travel out of province or country to access them. And so then they get stuck with me, and we have to figure out how to kill the bugs in an efficient manner that doesn't involve pharmaceuticals. So this patient case exemplifies this. So this is a case where the patient, prior to seeing me for the first time several years ago, 25 years previous to seeing me, she was diagnosed with fibromyalgia. And 2 years before seeing me, she had a tick bite with a bullseye rash, developed all of these crazy, unpleasant symptoms around pain, neurological symptoms, cardiac symptoms, etc. And unfortunately, it was at a time when people were still semi-regularly being told that Lyme disease doesn't exist in Nova Scotia, so she was not treated. But of course, her healthcare provider was, concerned and wanted to try to figure things out. So she had all of the, CT scans, MRIs, every blood test under the sun. Everything came back normal. So she suffered for a year without treatment, and then somehow managed to finagle a 3-week course of doxycycline, 100 milligrams twice a day, and she, quote unquote, felt amazing. And she continued to feel amazing until 3 weeks later when the prescription ran out, and then she rapidly regressed back to baseline. And even though she had this amazing response, she couldn't get a refill of the doxy. So when she came in to see me, I heard her case and I thought, well, it sounds like the killing approach was working really, really well for you. So why don't we try to replicate that as best we can? And so I recommended that she go on a potent antimicrobial herbal formula, and I recommended that she start doing something called intravenous laser therapy. We do a lot of intravenous therapies in our clinic. I've tried many, many different ones for patients dealing with known or suspected persisting infections, and the intravenous laser therapy seems to be the strongest one, so that's what we typically recommend for these cases. So she had a treatment, she was on her herbs, she came in a week later and she had a notable Herx reaction. So the Herxheimer reaction, also known as a die-off reaction, also known as we started killing bugs and I feel worse because we're killing the bugs too aggressively reaction, she had one of those. And one of the silver linings to a Herx reaction is that it at least gives us some good clinical insight that our treatment's probably working. So she had a Herx, and I thought it was because the laser potency was too strong, so we lowered the dose, and then the next time she came in, like a week later for her next treatment, and she said, yeah, I tolerated that a lot better. So in hindsight, it looks like we Herxed her because the laser was doing too good of a job. I know that some clinicians, have the mindset that if you're not Herxing, the treatment's not strong enough. I am an anti-Herxer, just admittedly. If you're Herxing, it tells me, okay, we're on the right track, but we need to back off. And I could talk for an hour about why I think that, but that's just, I'm a big baby, I can't see my patients suffering, so it's all about me at the end of the day. So, 1 month after her first visit, she'd had about 4 IVs at that point. She was on the herbs, and she was doing a lot better. Only mild eye burning, the numbness and tingling were gone. Her energy was up to a 7 out of 10, where 10 is really good. Some of her joints were feeling great. Some joints were still hurting. So it sounded like we were on the right track. We were only a month into it, so we kept up the same protocol. And a month later, she said, I feel really good. She had virtually no symptoms at all. We kept up the protocol for a few more weeks just to make sure that we got any persister forms or whatnot, just to be on the cautious end of the spectrum. She weaned off the protocol, was feeling good. Over the next year, she had some little flare-ups that came up, so she'd come in for a booster IV, go on a couple of weeks worth of herbs. It would nip it in the bud within a couple of weeks, and up for the last 2.5 years, she's been doing really, really well. So once again, sometimes there's the cases where the patients just need some killing treatment, and they do really, really well. Whether it's with pharmaceuticals, non-pharmaceuticals, we just need to use the right tools. So the next case type is the patient type where they come in saying, I've been treated for Lyme and or co-infections, and I'm still really quite sick. Maybe I feel 25, 30% better. Maybe I Herx like crazy, and then once the Herxing wore off, I was right back to baseline. Maybe I feel worse than before I started treatment. But these types of patients, what their cases say to me is that, you've been having the killing approach, and it's either worked partially or it hasn't worked at all, or it's just flared you up, and we need to kind of figure out what else is going on here. And that could be one of many things, but we'll see how this case looks, and you'll get a sense of what that might look like. So with this patient, 4 years before seeing me for the first time, she had been traveling down south. She got a bad case of food poisoning. That resolved, but then about a month later, she developed this extreme bloating. She was exhausted, couldn't sleep, and her arms and legs became weak to the point where she needed a wheelchair. So really, really sick. So, understandably, and there were a myriad of other symptoms as well, a lot of neurological stuff, and she was not doing well. So of course she had CT scans, MRI, lumbar puncture, scopes from the top end and the bottom end, every blood work test you can imagine. Everything came back normal. She went to see a couple of different neurologists to get a second opinion, and they basically said, we're going to call it MS, even though all the tests for MS didn't come up positive, but that's the closest thing your clinical picture fits. And so she had this MS diagnosis and was really not doing well. So she came to see me. So in her case, I recommended that we talked about the pros and cons and limitations and everything, of course, of the testing, but ultimately settled on doing this urine PCR test. PCR stands for polymerase chain reaction, which is just another way of saying it's testing for the DNA of different microbes in a patient's urine. And so essentially, as it says in bold there, if we find microbial DNA in the urine, then it suggests that, well, it's coming from inside the body, because that's where urine comes from, as everybody knows. And So if the microbial DNA is coming out in the urine, well, maybe those bugs are living inside the body as well. So, she decided to do this test. I thought it would be reasonable, and she could thankfully afford to do it. And then I also recommended that she get tested for something called small intestine bacterial overgrowth, because I thought, well, there's a bunch of studies showing that if you get food poisoning, you can develop this bacterial imbalance in the gut. It can throw off your immune system, cause a bunch of pain and inflammation, fatigue, etc. And I thought, let's maybe rule that out as well. So a week later, she came back in for her bacterial overgrowth test results, because they only take a week to get back. The urine test takes about 5 weeks to get back. And the test said that, yes, you do have this bacterial overgrowth. So I recommended that she go on some herbs to treat that. And so 5 weeks later, she came in for her urine test results, but I asked her, well, how are you doing? And she said with the intestinal herbs, she noticed that she was having longer stretches of less bad days. So when she first came to see me, she said, every day is bad, but some days are less bad and some days are horrific. And so she was finding that in the previous 5 weeks, she was having longer stretches of less bad days. So a little bit of improvement there. Also, said on one of the previous slides, she had this ravenous appetite despite the fact that she was rapidly losing weight. So her appetite had normalized in the previous 5 weeks, and her weight seemed to be stabilizing as well. And then this internal body tremor, which I've seen dozens of times in my patients, and they're like very scary and they don't know what's going on, very commonly related to Borrelia or mold illness every once in a while from some intestinal thing going on, that was reduced as well. So seeing some little improvements, but not hitting it out of the park yet. And so her test results, as we'll look at on the next slide, they indicated or gave evidence suggesting that she had an issue with Bartonella henselae, one of the co-infections of Lyme. Her clinical picture really fit that, so I wasn't super surprised. So I recommended that she continue the intestinal herbs because they seem to be helping a bit, and I recommended she go on some anti-Bartonella herbs. So this is these are her test results. And so these are all the different microbes that are tested for, looking for the DNA of these microbes in the urine. There's various species of Borrelia, Bartonella, Babesia, and then Ehrlichia and Anaplasma. So whichever types of DNA they find, there's a little check mark. You can see the check mark beside the Bartonella henselae. Sometimes multiple things come up, and then on a semi-regular basis, we see nothing come up. So we get negative results regularly, but in her case, we found it indicated Bartonella DNA in her urine. So 7 weeks later, bearing in mind she had started on these Bartonella herbs, she was still taking the intestinal microbe herbs, she had emailed me a few days into treatment saying, full dose herbs, I'm herxing like crazy here, so we talked about lowering the dose, building it back up more gradually, and so after a couple of weeks, she found a half dose was what she could tolerate. And so she found that after the 7 weeks of that, she said, things are moving in the right direction. She could go for short walks. Subtext being, she wasn't in a wheelchair anymore, so that's like kind of amazing just in and of itself. So she could go for short walks, and her neurological symptoms were much reduced, and her pain and fatigue were they were kind of the hallmark symptoms. So when patients come in, I'd like to ask, what are the things that are bothering you the most? You got a million things going on, but what are the top 3 to 5 things that are going on? And on the first visit, it was, well, I can't walk, and I have these crazy, scary neurological symptoms, and I've got some pain and fatigue. A lot of it, but those are lower on the list. At this visit, she said, the neurological stuff is lower on the list. Pain and fatigue are the hallmarks. So we were seeing some notable improvements with her neurological symptoms. So I recommended she stay on the protocol. And shortly after that, just based on the test results and how she was starting to get better, she managed to finagle some doxycycline, but only a prescription of 100 milligrams once a day, which is quite low. Oops, oh, that's the backwards button. Oh man. High-tech Bridgewater. Okay, so 6 weeks after that, symptoms were improving further, energy, stamina, etc. She's like, I'm feeling better, but I still can't drive. I'm having trouble sleeping, etc. She stopped the intestinal formula because we figured that had probably done about as much work as it could, but she kept up with the doxy and the herbs. A month later of that, she said, I feel about the same. She decided to stop the doxy because she felt like she had kind of plateaued and it was causing some intestinal upset, so she stopped it. We had done some other testing for her certain genetic susceptibilities, and her test results indicated that she may have a harder time making the active form of vitamin B12. So I put her on some active B12, and 1 month later she said, I got over the plateau, my energy's better, I can actually exercise now, but if I exercise for more than a few days, then I will crash, so she had to be careful. So 2 months later on the same protocol, she was like, I'm just gonna stick with this for now. Let's see how it goes. Too much testing, too much treatment. Let's just stick with this. 2 months later, she's like, I'm still doing well, but I've really plateaued. So I asked, the question, well, what's bothering you the most now? And I thought she was gonna say pain, fatigue, or something like that. And she said, well, every time I get stressed, I get heart palpitations, my heart starts to race, I get itchy, and I have a rash. I'm like, well, there's a curveball. What's going on there? And that can oftentimes mean that there's a histamine intolerance or something called a mast cell activation syndrome, where there's too much histamine floating around in the body. Many things on the differential diagnosis list for that, including Bartonella, interestingly enough. But I thought maybe there's a mold component, because mold illness can cause that, and pain and fatigue as well. So my second question, not rocket science here, have you ever been exposed to mold? And she said, why, yes, I have. I worked in this really moldy building for a number of years, and after my first year of working there, I developed chronic sinus issues. So I thought, well, maybe you had a mold colonization of your sinuses. There's a bit of evidence suggesting that can happen. So I recommended that she do another test looking for evidence of mold toxins in her body, and we saw these numbers coming up off the chart for ochratoxin, some elevated mycophenolic acid, and citrinin, which I realize to most of you that probably doesn't mean much. I just like saying those names, and it makes me sound smart, and good Scrabble words, just FYI. So we started a mold protocol based on that, and 2 months later, energy much better. She could drive now. She can exercise regularly without crashing. I feel 90% better 90% of the time, is what she said. So still not 100% healed, but a heck of a lot better. So sometimes, when we're beating patients over the head with antimicrobials and they're not getting all the way better, especially when they're still quite sick, then it can mean there's something else going on. Now, I have been yapping too much, and unfortunately, I can't do this next case justice, but the punchline here is that sometimes when patients have been treated with antimicrobials for months or years, and they say, I'm doing so much better. I was racked with pain in every part of my body, and now it's only my knees when I overdo it on the weekend, or I couldn't get out of bed, I was so tired, but now I can work. But by the end of the week, I have to take it pretty easy on the weekend. I kind of have these crash days, things like that. So I'm like functional, I have my life back, but I'm still not back to where I was pre-Lyme, co-infection, whatever it was. And so in these cases, sometimes there's still some residual infection kicking around, and we'll sometimes do the ELISpot test that Dr. Lambert was talking about to give us some insight whether that's going on. Sometimes we'll start treating biofilms, which were mentioned, much to my joy, because I could talk about biofilms all day. And sometimes there's just something else going on. So in this particular patient's case, we wound up doing a test for the mitochondria, which, once again, very happy that was mentioned already, these little energy-producing units in the cell. The test results indicated that there was lower than optimal mitochondrial function. So I recommended the patient go on a couple of supplements, get his mitochondria supported, and within 6 weeks, feeling a lot better, just mopping up some of the residual symptoms. 2 months after that, he feels like his old self the vast majority of the time. So all this great antimicrobial work was done. There were just still some residual symptoms left. His body just needed more support healing from the damage of these darn microbes. The very last case type, which I'll fly through in 1 minute and 14 seconds, is the case where the patient, you think they have Lyme, but they don't. So this patient came in saying, I've been at a 3 out of 10, so very low energy for the past 8 years. I've had migrating pains throughout all my many joints for 5 years, a lot of brain fog, these muscle spasms. I've had CTs, MRIs, all the blood work under the sun, everything comes back normal. So, if we pulled the room, sounds like Lyme disease, right? Or co-infections, highly suspected there. And that was definitely on my differential diagnosis list. However, she also mentioned that 10 years ago, she started getting this severe bloating and heartburn. And so I thought, well, let's look at the timeline. 10 years ago, you get all these crazy digestive issues. 2 years later, you're tired, which can happen from Lyme and co-infections, but also if you're not absorbing your vitamins, minerals, your mitochondria can't make energy without those things. So you're gonna get tired. A few years later, you start getting all this pain. That can happen when your gut's chronically inflamed. You don't have the nutrients to promote proper functioning of your various tissues. So I thought maybe there's something going on with your intestines. I do test for more things than just small intestine bacterial overgrowth, but that made sense with her case. Lo and behold, she was positive. Started her on treatment. 6 weeks later, big difference overall with virtually everything. 6 weeks after that, energy's almost perfect, gut's doing well, joint pain's almost gone. put her on a gut healing protocol, and she's doing just great. So at the end of the day, if it was Lyme and co-infections, that protocol would not have been wholly successful the way that it was. So, how do we know when it's not Lyme? Well, it takes, seeing hundreds and hundreds of cases, and, when your kids go to bed, you just read research and focus on chronic disease and all that stuff. So it's not always easy to tell when it's not Lyme, but sometimes it's not Lyme, and we as clinicians always need to keep that in mind. I'm over time. I apologize to the organizers, sacrificing a minute and a half of question time, but thank you for your attention. I will be posting a recording of this on our Facebook page, which is listed up there, and just me doing a voiceover of my PowerPoint, not quite so rushed, but thank you.